We now move on to the vasoactive intestinal peptide. The vasoactive intestinal peptide is an enteric neuropeptide hormone that mainly acts to relax smooth muscle and stimulate intestinal secretion. It's very important in intestinal secretion, vasodilation, and pancreatic secretion. First of all, the source of VIP is neurons. It's from the neurons, not classic endocrine cells. So that's why we call it a neuropeptide hormone, an enteric neuropeptide hormone, because the source of its release is from the neurons. The main sources are the enteric nervous system neurons, the parasympathetic nerve fibers, then also there's a minor source in the pancreatic islet cells, and then the central nervous system neurons. So where does it come from? It comes from the enteric nervous system neurons. It comes from the parasympathetic nerve fibers. A minor source is also pancreatic islet cells, and then the central nervous system. Where is it located in the GI tract? In the intestinal mucosa, in the pancreas, and the colon. So VIP functions, this vasoactive intestinal polypeptide functions as basically a neurocrine hormone. Now, what's the stimulus for VIP secretion? When is it going to be released? VIP is released due to neural stimulation. And these are triggered by parasympathetic stimulation, intestinal distension. So there's like food or bolus in the intestine, and that's distending the intestine. So that leads to the stimulation. Food in intestine leads to the stimulation, and also enteric reflexes. So basically, distension and vagal stimulation. As it says here, so any parasympathetic stimulation, intestinal distension, food in intestines, and enteric reflexes. VIP is therefore part of the enteric nervous system regulation of digestion. Now, the main physiologic effects of VIP. Basically, what it causes is it causes intestinal secretion of water, electrolytes, mainly chloride and sodium, and bicarbonate. And where is it occurring? It's occurring in the small intestine and pancreas. Now, so basically, the result is watery intestinal fluid. It leads to intestinal secretion of water, electrolytes, mainly chloride and sodium, and bicarbonate. So you have water, electrolytes, mainly chloride and sodium, and bicarbonate coming in the intestine, in the area of the small intestine and the pancreas, which leads to watery intestinal fluid. It also leads to smooth muscle relaxation. So it relaxes the smooth muscle in four places: in the lower esophageal sphincter, in the stomach, in the gallbladder, and the intestinal smooth muscle. So all of this helps to regulate GI motility. Right? So VIP relaxes smooth muscle in lower esophageal sphincter, in the stomach, in the gallbladder, and in the intestinal smooth muscle. So all of this helps to regulate the GI motility. Third thing, it causes vasodilation. So VIP causes vasodilation of the intestinal blood vessels. Hence, it's called vasoactive intestinal peptide. So the vasoactive word is part of the hormone name because it causes vasodilation of intestinal blood vessels, which leads to increased intestinal blood flow and increased nutrient absorption. It also leads to pancreatic secretion. So VIP stimulates the pancreatic bicarbonate secretion. This is similar to secretin. Secretin also helps to neutralize gastric acid. Vasoactive intestinal polypeptide also helps to neutralize gastric acid. So it decreases gastric inhibition. It also inhibits gastric acid secretion. So VIP decreases stomach acid production. It inhibits the gastrin release and reduces parietal cell acid activation. So what kind of things do you have in it? You have in the intestine, you have increased water and electrolyte secretion in the intestine and the pancreas. In the smooth muscles, you have relaxation. In the blood vessels, you have vasodilation. In the pancreas, you have bicarbonate secretion being increased. And in the stomach, you have decreased gastric acid secretion. Now, how is it regulated? We told you it's regulated mainly by neural mechanisms. The stimulators are parasympathetic activity, intestinal distension, and enteric reflexes. Inhibitors would be somatostatin and by decreased adrenergic input. Somatostatin suppresses many GI hormones, including VIP, and also adrenergic input here. Now, VIPoma is a rare, this non-alpha, non-beta cell pancreatic tumor is basically a rare pancreatic neuroendocrine tumor that secretes excessive VIP. It most commonly arises in pancreatic islet cells, usually in the pancreatic tail. These tumors produce large amounts of VIP. And the effects of VIP will be basically watery diarrhea. Because what was this doing? It was leading to a lot of watery intestinal fluid. So it's going to cause watery diarrhea here. Now, in the electrolytes that were being secreted here, we remember that we said specially chloride and what else did I say? I said specially chloride and sodium. So here we're going to lose the chloride and sodium, right? When we lose the chloride and sodium, what do we get? We get electrolyte loss. That is going to lead us to severe dehydration. So you have decreased potassium and decreased chloride, achloridria, and hypokalemia. This is classically known as the WHA syndrome, where you get a watery diarrhea, dehydration, and hypokalemia and achloridria. So the watery diarrhea is because the VIP stimulates the intestinal secretion of water and electrolytes. The patient can lose 3 to 5 liters of stool per day. Dehydration is because there's a large fluid loss. You get overall severe dehydration. And hypokalemia is because potassium is lost in diarrhea, and that leads to low potassium. So you get muscle weakness and arrhythmias. And achloridria is because you're losing VIP basically inhibits the gastric acid secretion, so you're losing the stomach acid, this very low stomach acid, and that leads to achloridria, right? And you diagnose this based on severe watery diarrhea and high plasma VIP levels, or a CT or MRI that shows pancreatic tumor. For treatment, we've already studied that we can use somatostatin analogs like octreotide, which inhibits the VIP secretion and reduces diarrhea. You will need to give fluid and electrolyte replacement, and you might need to do surgery, right? We now move on to the nitric oxide. Nitric oxide is a gaseous signaling molecule. It basically acts as a local transmitter. This is also a neurotransmitter. It also acts as a vasodilator, right? So it's a neurotransmitter, it's a vasodilator, and it's a gaseous signaling molecule. The key concept here is it acts paracrine, which means it affects nearby cells rather than traveling long distances in blood, right? Now, the sources of nitric oxide include the enteric inhibitory neurons, which are the Na and C neurons. And then we have the endothelium. So there is an endothelial nitric oxide. This is also known as eNOS, which is the endothelial nitric oxide. Um, this basically, the one that comes from the endothelium causes vasodilation. This regulates blood pressure and blood flow. It's responsible for nitroglycerin-like vasodilation. It's important in erection physiology. And then we have the neuronal nitric oxide, which we also call NOS. This comes from these neurons and also the enteric nervous system and some brain neurons. This acts as a neurotransmitter. It causes smooth muscle relaxation. It's very important in GI tract and lower esophageal sphincter relaxation. So this is the isoform that's relevant in achalasia that we'll see just ahead. And then we have an inducible nitric oxide, which basically comes from macrophages and immune cells. And the functions of this inducible nitric oxide is that it produces large amounts of nitric oxide during inflammation. It kills bacteria and pathogen, and this is part of the immune system also, right? So we have three types of sources for the nitric oxide. We have endothelium that leads to vasodilation, and then we have the neurons. The neurons one leads to neurotransmission and smooth muscle relaxation, and then we have the iNOS, and this iNOS comes from macrophages and it leads to immune defense. Now, mechanism of action of nitric oxide. Basically, nitric oxide diffuses into nearby smooth muscle cells and activates something called the guanylate cyclase. This guanylate cyclase increases the cGMP. Once the cGMP pathway is increased, this leads to smooth muscle relaxation, and this is why nitric oxide causes vasodilation and sphincter relaxation. I'll repeat it. So the nitric oxide diffuses into nearby smooth muscle cells and activates guanylate cyclase. It increases cyclic GMP, And the cyclic GMP leads to smooth muscle relaxation. So this is why nitric oxide causes vasodilation and sphincter relaxation. Effects of nitric oxide are very peculiar. So nitric oxide mainly causes smooth muscle relaxation. Number one is it causes vasodilation. When it causes vasodilation, it relaxes the vascular smooth muscle. The effects of which is basically decreased in blood pressure, increased in blood flow, and it prevents platelet aggregation. So it's important in coronary circulation and erection physiology, right? Now, it also gives you, so first thing is vasodilation. And we said that that's important for us in coronary circulation and erection physiology, right? Because it's preventing any platelet aggregation, it's decreasing blood flow. It's increasing blood flow and decreasing blood pressure, right? The second thing it does is GI smooth muscle relaxation. And that's important for us here because it basically relaxes the lower esophageal sphincter. Now, the lower esophageal sphincter is important for us because all of this leads to relaxation of intestinal smooth muscle, and the relaxation of lower esophageal sphincter leads to regulation of peristalsis. So, overall, it regulates peristalsis. Now, the neurotransmission one, the NO that acts as the NANC neuron. So, the NO acts also as a non-adrenergic, non-cholinergic neurotransmitter, NANC, non-adrenergic, non-cholinergic neurotransmitter in the enteric nervous system. So, meaning it works alongside but separate from the acetylcholine and separate from the cholinergic, the norepinephrine also. It acts on itself also, right? And then it also has a role in the immune defense. I told you the large NO production from macrophages that helps to destroy bacteria, parasites, and tumor cells. Regulation of nitric oxide depends on nitric oxide synthase activity, and stimulators is basically how is it stimulated? It's stimulated by shear stress in blood vessels. When blood flow increases, endothelial cells release nitric oxide, acetylcholine, parasympathetic. Now, acetylcholine also increases NO release, parasympathetic stimulation increases NO release, and calcium. Since nitric oxide enzymes require calcium and calmodulin, so calcium also increases it. Now, inhibitors, when is it not increased? Oxidative stress destroys nitric oxide. So remember that whenever you have oxidative stress, you destroy the nitric oxide. This reduces endothelial function. So it occurs in diabetes, hypertension, and atherosclerosis. Now, the most important clinical link is basically nitric oxide and achalasia. What happens is when you swallow, food moves down the esophagus. The lower esophageal sphincter muscle must relax. Relaxation occurs due to enteric inhibitory neurons that release nitric oxide and vasointestinal peptide. These are NANC inhibitory neurotransmitters. When I say NANC, it's uh, what did I say? I forgot. So whenever I say NANC, I didn't want to be wrong, so I wanted to make sure I'm saying the right thing. Whenever I say NANC, it's non-adrenergic, non-cholinergic, right? So the nitric oxide and VIP are VIP. When I say VIP, it's vasoactive intestinal polypeptide. These are NANC, non-adrenergic, non-cholinergic inhibitory neurotransmitters. Relaxation occurs due to enteric inhibitory neurons that release nitric oxide and VIP. So what happens is when you swallow, the enteric inhibitory neurons are activated, the nitric oxide is released, and this nitric oxide being released relaxes the lower esophageal smooth muscle sphincter, and food enters the stomach. Now, achalasia occurs when inhibitory neurons of the myenteric plexus degenerate. So when inhibitory neurons of the myenteric plexus degenerate, these neurons normally produce nitric oxide and VIP. Loss of these neurons causes failure of lower esophageal sphincter, relaxation, and loss of peristalsis. So what happens is this loss of myenteric neurons. This reduces nitric oxide release. The lower esophageal sphincter cannot relax, and food accumulates in the esophagus. And this leads to esophageal dilation. So patients develop dysphagia, regurgitation, chest pain, and weight loss, right? A classic imaging sign would be when you look at barium swallow. So, a classic imaging sign would be like you get this bird beak appearance when you look at the barium swallow. So, you get a bird beak appearance here because the lower esophageal sphincter remains tightly closed, right?